you've got patient A and you've got patient B. All right? Mm-hmm. This patient has an AMI, an acute myocardial infarction. This patient has an acute myocardial infarction. Oh, but this patient also had a CVA, a hip fracture, a skull fracture. Oh, and let's throw in some appendicitis while we're there. Okay. Do we want to code all these things?
I would think, yeah.
Absolutely. The codes are there to tell us the story of what is wrong with the patient. And if we can't look at the codes and tell what was wrong with the patient, then we haven't done a good job of coding. The other thing to keep in mind is if we don't code these extra codes over here, have we really shown the severity of the illness in that patient? No. Which patient is sicker? This one, considerably more sicker. So if we don't show all of these things here, then we basically said these two patients are equal, when in fact they're not, are they? So coding and knowing what to code is very critical, and making sure that you've coded all the pieces and parts is extremely critical. Take a look at the bullets. For UHDDS reporting purposes, the definition of other diagnosis includes only those conditions that affect the episode of hospital care in terms of any of the following. And I want you to make sure you realize that we're talking about the current episode of hospital care, including clinical eval, any kind of treatment, anything that got some more studies, procedures, or consultation, anything that caused their length of stay to be longer, anything that caused their increased nursing care. All right, we're going to code for those things that are relative to the current episode of care. All right, you have a patient who's in the hospital because they have breast cancer. And they're going to have a mastectomy. Well, 2 years ago, they had an ingrown toenail removed. And the doctor put that on the chart, okay? Are you going to code the ingrown toenail?
No.
Why not?
Because it happened 2 years ago.
And more importantly, it's not relevant to the current episode of care. That's exactly right. Okay? Same patient. This time, though, they've got a history of uterine cancer.
Yes.
Why?
Because it's a history that's running in her line and family.
We've got this CA situation. We know that uterine cancer and breast cancer have relationships. So now this potentially could be relevant to her current episode of care, and so we will code it. Exactly. So only code those things that are relevant to the current episode of care. Take a look at page 25. Doctors who like to use a problem list. Well, let's define what a problem list is. If I have a record, and my record is as thick as my coding book, wouldn't it have been easier if maybe on the left-hand side on a page that somebody kept a running list of every diagnosis I had ever come in with? Yeah, that's what we call a problem list. Every problem the patient has ever come in with. You may find that in some doctor's offices. Most of them don't take the time to do it. But at least it enables them to scan and see everything that's been going on with the patient. But by doing that, you have to realize that sometimes the doctor will go back to the previous list and bring things forward that maybe in his mind he thinks are relevant. But they aren't necessarily to the current episode of care. They may be relevant to the patient in some other way. They may be relevant because they've got a history of those things, but it doesn't necessarily make it relevant to the current episode of care. So take a look at that. Physicians sometimes include in the diagnostic statement historical information or status post-procedures performed on a previous admission that have no bearing on the current stay, much like that removal of the ingrown toenail was. Such conditions are not reported. However, history codes may be used as secondary codes if the historical condition or family history has an impact on current care or influences treatment. So there's really some more, verbiage there about what I was just saying to you. You can code history of anything you want to in this book. You will learn that when we go to V-codes. You can code history of this, history of that, history of something else. But the issue is, do you really need to? And that's a decision that you're going to have to make independently for every chart you've got in front of you. You're going to be making those decisions. Goes on to give the example of the patient coming in with an acute MI. Physician noticed in the history that the patient with status post-cholecystectomy had been hospitalized a year earlier for pneumonia. At discharge, the physician documented the final diagnoses as an AMI and status post-chole and a history of pneumonia. Only the MI is coded and reported because the other two were not relevant to the current episode of care, even though the doctor put it down. So just because the doctor put it down doesn't mean that we code it. Just because they don't put it down doesn't mean we don't code it. We've got brains, we've got a body of knowledge, we're being paid to extract from the chart what needs to be extracted. How much training has the physician had in extracting the right information for coding purposes? Pretty much none. They'll have had some in some med schools, but for a lot of times it's pretty much none. All right, number 2, other diagnosis with no documentation supporting reportability. Okay, you've got a doctor who's included a diagnosis in the final diagnostic statement. It should ordinarily be coded. If there's no documentation in the record, then you should consult the physician to see whether the diagnosis meets reporting criteria. If so, the physician should be asked to add the necessary documentation. Example, you've got a 10-year-old came in with an open fracture of the tibia and fibula following a bicycle accident. Upon exam, the physician noticed a nevus on the leg, a mole, and the patient had a small asymptomatic inguinal hernia. Those diagnoses were documented on the face sheet. The fracture was reduced with internal fixation, but neither the nevus nor the hernia was treated or further evaluated. The nevus and hernia are not reported because there's nothing to indicate that they had any effect on the episode of care. Now, if the doctor had decided that the mole, the nevus, had to come off and he removed it, boy, that changes things entirely, doesn't it? Or for that matter, if the inguinal hernia had been repaired, that changes things. So you're not going to report if it's not relevant. But if it was something that happened and you think it was relevant, then you're going to query the physician and ask them to provide the documentation. Now look at example number 2. Patient came in with an AMI. Physician also included in the diagnostic statement a strabismus and a bunion noted on the physical exam. Review of the record revealed no further reference. Therefore, no codes for the strabismus or bunion would be assigned. And doctors, for fear of not documenting appropriately, will sometimes over-document, and they will pull in things that are not really related to the current episode of care. It's just a mindset, trying to make sure they're covered, and so that's where we're kind of the watchdogs to make sure they're not putting out stuff extraneously. Okay, chronic conditions. You'll code chronic conditions based on how severe the condition is, the use or consideration of alternative measures, or an increase in nursing care required in the treatment of the principal diagnosis due to the coexisting condition, the use of diagnostic or therapeutic services, the need for close monitoring, or modifications of nursing care plans. All right, what in the world is that talking about? Perhaps I have a chronic bronchitis. I just always have it. But I'm here because I'm a male and I have an inguinal hernia. Well, one's not really related to the other, is it? Unless the anesthesia perhaps gave me a problem that made the bronchitis flare up and then it became an acute bronchitis. If that's the case, then I'm getting some treatment for that acute bronchitis problem.